is that?
Yeah, I mean, if you are just if you go down the right lower corner,
Yeah, yeah.
and then there is that screen. Yeah, up there, up. You, yep, that's the one. Okay.
Okay.
Okay, fantastic. So it's a great pleasure, and I'm really excited to have Dr. Jag Bawan back on the program, who is the with the minor professor of dermatology and pathology and head of dermatopathology section in the Department of Dermatology in Boston University School of Medicine. What you need to know about Dr. Bawan, and I think that actually he doesn't necessarily need an introduction. He's one of the towering figure of dermatopathology. He has been the president of the American Society of Dermatopathology. He's one of the recipient of the Founders Award of the American Society of Dermatopathology. And with this program, he is a big teacher. He's a great teacher, and that was also uh, he also received the Walter Nickel Award for the excellence in teaching of dermatopathology by the American Society of Dermatopathology. So I'm really excited to have him because he's a phenomenal dermatopathologist, but at the same time, he's an amazing teacher, and his lectures are always exciting. I know that you are extremely busy, and that's why I'm very grateful for you to come on this program and giving this lecture for us on benign and malignant epithelial neoplasm. Thank you so much.
Thank you, Laszlo, and thank you for that very kind introduction that I really don't deserve. And I will try my best to present so that it's useful to our participants. And so today my talk is talking about benign and malignant neoplasms, epithelial neoplasms, and I will start with this photomicrograph. And I don't know if there is a mechanism for me to ask from the audience questions or not. If it's not practical, then I'll just keep going.
It is usually we are muting the conference because if there would be a lot of people on the call, then there would be a very annoying noise. So what we usually do is that, and you can do that, that you can ask a question, and we have a chat box, and I will ask the audience to try to answer your question. So there will be a delay on this, but we can give it a try.
Yeah, so for a few things, I would like to do that because I think it will make it more interesting to have the audience participation. This is photomicrograph. One is the top part is the low power or scanning power photo, and then the lower part is the higher magnification of the same process, which basically shows epidermal hyperplasia, and there is hyperkeratosis, there is some hypergranulosis, and if one were to make a differential diagnosis, you will think about possibility of epidermal nevus, you will think about seborrheic keratosis, you might even think about a wart or verruca vulgaris, although there is no cholestatic change. So once you have that kind of a differential diagnosis, then you can start to put other things into the mix to see, well, what will eliminate. So for example, for verruca vulgaris, you don't see the cholestatic change, you don't see the really the inward proliferation of squamous epithelium towards the center, and you don't see the parakeratosis the way you will see in a wart. So these are the changes of an epidermal nevus. But there's the next photomicrograph. I would like to ask a question to the audience. What will they think if they saw this?
Okay, I'm looking for the chat window. I'm waiting for the answers. If you guys can. Bawan's disease.
So it's not any trick. It's just a very simple process, right? You are seeing polypoidal structures which are lined by epidermis or epithelium on all sides.
Condyloma.
Right, or fibroepithelial polyp.
Yeah.
Right, skin tags. And the reason I wanted to show you this photomicrograph. Do we have any other answers, or we can go on?
No, we can go. There were Bawan's disease and condyloma.
Okay, so so basically, yeah, condyloma would be a possibility, but there is really no hyperplasia here. If you see, these are really light skin tags, and I wanted to show you this because in the epidermal nevus there can be papillary projections like this, and if you want to do a shape biopsy like this from here, you will see how you will get fibroepithelial polyp-like structures. And the case that I just showed you is the actual case that I got from a excised lesion of epidermal nevus in which they did a superficial shape biopsy, and we got these little tiny papules, and we're saying these are fibroepithelial polyps, except when you see the clinical history, it says lesions, group lesion present since birth, then you say, oh my God, this is epidermal nevus. And the reason why that happens, you can now see that this is actually epidermal nevus, and you can see here that these are the papillary projections. When if you shave, they will appear to be separated, but eventually they are connected with the epidermis, but you don't see that in this plane. The other variants in which epidermal nevus can present usually be features like hyperkeratosis verruciforme, like picture, epidermal Lytic hyperkeratosis, which I will show you some examples, Seborrheic Keratosis like, which I will show you an example. Psoriasiform, that will be again I will show an example, which will be similar to the inflammatory linear epidermal nevus. It could be very quiet, like almost like a wart, like we talked about, and keratosis, like where you will see columns of columnar lamella. You can see focal acantholytic disc keratosis, or you can see features of nevus comedonicus. So let's see some of this example. This is the clinical photograph of an epidermal nevus, and you can see very closely set plaques in this region. And if you were to do the shape biopsy, now you can understand why you will get those fibroepithelial polyp-like lesions. This is another example of an epidermal nevus. In this, you can see focal keratosis alternating by hyperkeratosis. There is a sort of a psoriasiform epidermal hyperplasia, and there is some lymphocytic exocytosis. And in this photomicrograph, you see there is a major component of inflammatory infiltrate against keratosis you can see on the surface. So these features are features that one sees in ILVEN or inflammatory linear nevus. So characteristic features of a ILVEN or inflammatory linear epidermal nevus is hypergranulosis, parakeratosis alternating with hypogranulosis and orthokeratosis that we saw, acanthosis, lymphocytic exocytosis, and perivascular inflammatory infiltrate. And these lesions can be linear and therefore should be differentiated from a nevoid or linear psoriasis, which can have similar clinical features and some of the overlapping pathology features. The next entity that we want to discuss is, which is known as acanthosis nigricans, because here, even though the word is acanthosis, but truly there is no true acanthosis. There is a hyperkeratosis, there is papillomatosis, but the epidermis itself is not thickened, and that's why this is a misnomer. It's acanthosis nigricans. You can have, again, different pattern here. Most of them have these keratotic material in the valleys between the epidermal papillae, or you can have the church spiral-like configuration that you see in acrokeratosis verruciformis. And once again, in any of these entities, the clinical features are very important, and one must have a CPC in order to come to a right diagnosis, because otherwise it will be very, very hard. Okay. Here it shows classical features of acanthosis nigricans in the neck and axilla of this young man. Another entity that one has to see, which looks similar to acanthosis nigricans, but in this case now you can see there is hyperkeratosis, hypergranulosis, but there is actually acanthosis. There is hyperplasia of the epidermis. This entity, one cannot make a diagnosis of what? It could be a seborrheic keratosis, for example. It could be an epidermal nevus. But given this clinical presentation where there is hyperkeratotic, hyperpigmented papules correlating, sometimes forming this confluence and reticulated pattern is seen in confluent reticulosis of papillomatosis of Corto and Grujos, but classically we call these things as CARP. Okay. The next benign entity that we will discuss is, which is classical for pathologists, and they feel very happy when they see something like this because you can make a definitive diagnosis, which shows clear cell epidermal hyperplasia. And the thing characteristic about it is that there is a sharp demarcation between the normal epidermis, which is the normal color of the color of the epidermis, and as opposed to the pale appearing or clear appearing cells. That's why these things are called as clear cell acanthoma or pale cell acanthoma. And in higher magnification, one observes that there is a neutrophilic infiltrate within the epidermis, within this hyperplastic epidermis. So, and there is some papillodermal edema, so there is some telangiectasia. So if you were to see just this microphotograph, one could think of psoriasis, for example, and it has shared some features of psoriasis, and some people even feel that this may be a form firstly of psoriasis. But but from the histological point of view, the classical features is this sharply circumscribed epidermal acanthosis, which has a clear cell change with neutrophilic exocytosis, and this is quite classical. Sometimes it can show some degree of spongiosis, some serum crust, and you can see the very nice sharp demarcation here in the inset. Clinical features of a clear cell acanthoma usually can be eroded erythematous papule, usually in the legs, but can occur anywhere. The next entity that I'm talking about is where there is epidermal hyperplasia, but these keratinocytes are much larger than in a usual epidermis, and that's why the name is large cell acanthoma. There is nothing magical about it. This can be seen. There's no really good clinical counterpart. The clinical features may appear as a lentigo or as a macular seborrheic keratosis, and it's just one of those things that we see in pathology. And pathologists like to make lots of names and so that they can write papers and so on. But that's how this entity has been developed. There's nothing in my mind which makes it distinctive in terms of histological or clinical significance. But just to know that there can be epidermal hyperplasia with large cells and not to be confused with some malignancy. In this process, we can see again epidermal hyperplasia, but in this time we are seeing a lot of changes within the epidermis. And this change, even in this magnification, one can suspect that there is some loosening of epidermal keratinocytes, and this is acantholysis. So in this case, these are solitary lesions, and we call is acantholytic acanthoma. So the acanthoma because it's hyperplasia, and acantholytic because that's what it shows. So it's acantholytic acanthoma. Sometimes these things can be much more bulbous, and you can form these kinds of villus structures invading downwards into the dermis. Acantholytic acanthoma. Okay. The next entity we want to talk about is, again, all of these entities show epidermal hyperplasia, and in many ways shows the same features as you saw in the first slide in epidermal nevus, in which there is a acanthotic epidermis. But in each of these situations, there is some difference changes. In this photomicrograph, you can see clear sort of changes within the epidermis, and you say something is going wrong here. It's not like a normal epidermis. And when you go in the high power, you can see that there is hyperkeratosis, but there is a lytic change, or the epidermal keratinocytes are vacuolated to a great extent. So there is a degeneration of the keratinocytes, which is usually in the granular layer, but then it extends down to even up to the basal layer. So this is a process which is known as epidermal lytic hyperkeratosis. There's a difference between this and acantholytic process, where the actual cells break off the intercellular bridges and the cells become balloon and are separated. In this process, the actual cells are being disrupted with this vascular alteration, and this process is hyperkeratosis. This can be seen, of course, in several situations, including in epidermal nevus, as well as an ichthyotic process, a particular type of ichthyosis in which you can see this epidermolytic hyperkeratosis change. But sometimes one can see this as in solitary lesions, and then we term these lesions as epidermolytic acanthoma. Higher magnification of epidermolytic acanthoma. And this is just a clinical photograph. Nothing distinctive about it, just happens to be that somebody probably photographed this lesion and it turns out to be this epidermolytic hyperkeratosis. And that is why I always suggest to all my junior colleagues and our trainees that please take photographs whenever you're doing any biopsy. And now we have a rule in our clinic that all biopsies have to be photographed, because you never know what you're going to find. And this way, probably we can learn the clinical features of these entities, because otherwise we don't have any clear-cut ideas. Okay, so epidermolytic hyperkeratosis. By the way, both epidermolytic hyperkeratosis and acantholytic acanthoma-like features can be even seen as incidental finding in normal skin or in excision specimens, or totally unrelated to something else. So that's why the clinical features are important. If you see a lesion, this is a definite lesion in which you are seeing the changes, then we term it accordingly. Another entity which is again showing marked hyperkeratosis and epidermal hyperplasia, marked epidermal hyperplasia, we call it dyskeratotic acanthoma instead. In this case, the hyperplastic epidermis, acanthotic epidermis, is made up of dyskeratotic cells, where there is an individual cell keratinization, and you can see that in a little bit higher magnification. You can see these dyskeratotic cells throughout the epidermis, and we have termed this as a dyskeratotic acanthoma. Again, nothing clinically significant, but it's just one of those things that you see when people do biopsies. This is a very interesting case, and I think you will all agree, if you saw this, universally everybody will make a diagnosis of seborrheic keratosis, because you can see here very classically is a so-called pencil line lesion. That means if you draw a line between the two normal edges of the epidermis, the whole lesion is above that line. That is why it is known as pencil line lesion. There are pseudohorn cysts, and there is a acanthotic epidermis, which is made up of monotonous cells. And these monotonous cells are basiloid cells or basal cells. So these are the classical features of seborrheic keratosis. A reason I wanted to show you this case is because precisely this case I signed out as seborrheic keratosis. The clinician, instead of calling me, not happy with the diagnosis, sent me another biopsy, and this time he writes in his clinical features, previous path not consistent with clinical, because the patient has lesion present since birth. So immediately the diagnosis changes to epidermal nevus. And if you remember in the very beginning, I mentioned that epidermal nevus can have seborrheic keratosis-like features. So histologically, these things can be completely indistinguishable unless you have clinical features. So it's extremely important to have the CPC. And this is an epidermal nevus, which could be, you can think about it as a seborrheic keratosis, a pigmented seborrheic keratosis, but this lesion was present since birth. And this, in contrast, is seborrheic keratosis, which shows the typical stuck-on hyperkeratotic lesions, which may be pigmented. So we now move on to seborrheic keratosis. So you already saw one example of seborrheic keratosis, which shows the horn cyst and which is can be confused with epidermal nevus given the clinical findings. In this case, again, note the pencil line lesion, which is the lesion is completely exophytic and is made up of a acanthotic epidermis. There's usually hyperkeratosis, there are usually some horn cysts, but there may be instances where you will not see a horn cyst. It does not mean that this is not an seborrheic keratosis. But note again, it's an exophytic pencil line lesion. This is similar to the case that I showed you before. You can see the horns, but minimal amount of horns, but the cells are very basaloid and very uniform. And the pattern in seborrheic keratosis is a so-called adenoid pattern, where you can see they form these anastomosing channels and pseudo glandular sort of appearance because of these anastomosis. But again, typically a pencil line lesion, if you join the normal edges of the two normal sides, everything is above the above this line, and these things can be again formed by the basaloid cells. So typical seborrheic keratosis with typical pseudo horns and horns. Sometimes they can be having very clear cell morphology, similar to that you saw in clear cell acanthoma, except that here the sharp demarcation that you see in a clear cell acanthoma is not seen. Within the epidermis, of course, there is this acanthotic epidermis made up of the basaloid cells. There is no neutrophilic infiltrate or exocytosis that you saw in a clear cell acanthoma. So one should be aware of this clear cell variant of seborrheic keratosis. Seborrheic keratosis, like any other epithelial tumor, benign and malignant, may be pigmented. And the pigment is because of the increased melanin. And it's because of the presence of increased melanin, you see this pigmentation, and you can see that the keratinocytes are loaded with pigment. Unfortunately, in the books and in the journals, there is a misconception that has been conveyed to our readers that there is a pigment block, that the melanocytes have produced pigment, and because of the block, there is a increased this kind of appearance, which is completely untrue, because if you look at this thing, there is no pigment block. In fact, every keratinocyte has pigment. So there cannot be a block of pigment coming from melanocytes. What is happening here is that there are melanocytes which are producing a lot of pigment, and they are transferring that pigment into the keratinocytes. This process, if you want to conceptualize, it is as a normal white skin and normal black skin. The number of melanocytes are same, both in white and black skin for the same site, but they're producing a copious amount of pigment in black skin. And so, in a way, this is a black seborrheic keratosis versus a white seborrheic keratosis. Why one seborrheic keratosis does this and the other one doesn't, I don't know. Sometimes the seborrheic keratosis will be macular. They are very flat, both clinically and microscopically. And the distinction between sometimes a melanoma or melanocyte may be difficult. You may wonder if there are melanocytes here, but truly these are all keratinocytes. If in great doubt, of course, one can do stain to confirm that there is not a melanocytic proliferation, except for one situation I will just show you in a minute. So this is a pigmented seborrheic keratosis. Sometimes they can be irritated and inflamed. And once that happens, then the pathology is a little bit different. This is a variant of seborrheic keratosis where you can see the nest of keratinocytes within this acanthotic epidermis. And this process is known as clonal seborrheic keratosis, because there are clones of these keratinocytes which are forming these kinds of lesions, and we call this clonal seborrheic keratosis. And the seborrheic keratosis, just clinically, one should remember that if you have sudden onset of many seborrheic keratosis distributed in with a sudden onset, this signifying a sign of lesser trelot, which means that maybe there is a associated underlying visceral malignancy the patient may have. So just so that you be aware of it. And the same seborrheic keratosis like in black skin, these things are known as dermatosis papulosa nigra. The microscopic findings are similar. This is an inflamed seborrheic keratosis. When you see a lot of inflammation in the dermal thing, and sometimes inflammatory cells can be seen even in the acanthotic epidermis. One of the issues that happens in inflamed and then irritated seborrheic keratosis is that you begin to see some atypia. And sometimes the ATPI is so much that even for an experienced pathologist, the differentiating this from a squamous cell carcinoma becomes difficult. However, if you still in the low power, if you see, I mentioned the pencil line lesion, that the whole lesion is exophytic, it is above the lines of the normal epidermis on both sides, and then the ATPI is confined within that area. And if you see in higher magnification, there are these features where this nest of keratinocytes, these are known as eddies, squamous eddies, not to be confused with the squamous pearls that you see in squamous cell carcinoma that we will see in a little while. But these eddies are not showing much atypia, they're sort of uniform, they may show central keratinization, but many times they don't. So this is a classical example of seborrheic keratosis. And if you go in higher magnification, and if I show you only this photomicrograph on the right-hand side, it may be hard to distinguish it from a squamous cell carcinoma. But again, the low power configuration is extremely important in making a diagnosis of irritated seborrheic keratosis. In this, seborrheic keratosis is another example where the proliferation is inward, and that's why this is known as inverted follicular keratosis, as opposed to the pencil line lesion that you saw. This lesion is predominantly intradermal, it is going inwards. But the histopathologic features are similar to that you saw in irritated seborrheic keratosis. That means the numerous squamous eddies, which may or may not have keratinization in the center. So we have to be very careful that we don't mistake this for a squamous cell carcinoma. Sometimes, as I mentioned, when they are eroded, in this case, for example, the distinction from squamous cell carcinoma can be difficult, and one has to rely on the features of whether or not you are seeing any particular mitosis, any atypia, individual cell keratinization, and other features that one will talk about it. Another variant of seborrheic keratosis is this particular variant, which is known as Stucco Keratosis. And in Stucco Keratosis, there is marked hyperkeratosis. And epidermal hyperplasia is seen, but is the proportion of hyperkeratosis is much more than in an ordinary seborrheic keratosis. And these lesions appear as stuck on whitish keratotic papules, usually in the extremities. So here is the quantum of another variant of seborrheic keratosis, in which even in this magnification one can see that there is a large number of dendritic melanocytes. These all hyperpigmented cells which are seen are melanocytes. Let me show you in higher magnification. It's like a culture of melanocytes within ordinary seborrheic keratosis. So if you didn't have all the number of melanocytes and you just had this is a classical seborrheic keratosis. You can see the horn cells, you can see the pencil line lesion, you can see the basaloid cells, but it has numerous melanocytes, not to be confused with melanoma. For some reason, this particular lesion, the melanocytes are also proliferating, but these are benign cells, even though they're highly dendritic and they're numerous, and they may look a little funny and bizarre, but this is a completely benign structure. So people call it, they can call it a variant of pigmented seborrheic keratosis. Some people have given the name as melanocanthoma, but not to be confused with melanoma. This is the actual case that I had of a melanocanthoma, which unfortunately the picture, this is back in 1980, and people were not taking photographs at that much. And so I took the photograph of the gross specimen, and this was the original biopsy, and then the lesion was excised because people were not comfortable in leaving it alone. But as far as I'm concerned, this is totally benign lesion, melanocanthoma. Okay, so we move on to the next entity. Let's see what it is showing. Epidermal hyperplasia once again, and this is just to bring to your attention that some of the seborrheic keratosis can be confused with condyloma accuminatum. And this problem is in particularly more important when we get lesions from the genital areas, from the scrotum, from the labia, or from the shaft of the penis, and the clinician is asking a question to you whether it's condyloma or seborrheic keratosis. And as a pathologist, sometimes it's extremely difficult to make that distinction. If I see crypt of parakeratosis, if I see some hypergranulosis, keratosis and hypergranulosis, then I am likely to suggest that this is likely to be a condyloma. But sometimes it's extremely difficult. And many times the clinicians are pushing us to make that definitive diagnosis because the patient is unhappy to know that he has a condyloma or he has a condyloma or not. There is immunohistochemistry which one can do viruses, but as you can imagine, there are multiple number of Wart viruses, and it's not practical. There's no one particular immunohistochemical stain that one can do to eliminate or to confirm or to exclude the diagnosis of HPV. At least I'm not aware of this. Laszlo, if you are aware of some stain that can make a distinction, please tell the audience.
Actually, I was to ask this question from you, but what I'm using, and it is more of an exploration than probably true science. Are two things, actually three things. So I'm doing an HPV PCR testing, which is going after like 60 different kind of serotypes. I'm also doing P16 staining, and I'm doing P53 staining. What is interesting that usually I put more weight, and then that's why I'm saying that it's like an exploration for me. I put more weight into the coloration if the PCR test comes back like 16, 18 positive, and then I'm really carefully looking at the P16 staining. What I see that if it is like a large area of blotchy staining, then that's to me like true and concerning reaction, and then I'm telling it to the clinician, calling it Bawan papillosis. If it is just kind of like a sprinkling here and there, like we see sometimes, with P16 staining with melanocytic lesions, that checkerboard pattern, I'm not really concerned about. And then what is interesting that a lot of lesions, actually, there is a reverse correlation between P16 and P53, because in normal cancers like squamous cells of the skin other than genital area, the P53 likes to be upregulated, but at the genital skin, in P16 positive lesion, usually I found P53 negative. So that's my little, exploration on this topic.
Yeah, so it's. I mean, I'm glad that you're doing it and pursuing it, and maybe there will be an answer, if you have enough cases to talk about it. But this is clearly a very difficult issue, and for some clinicians, and maybe because they're pushed by their patients, it's a very emotional issue, and we have not found anything really satisfactory that can, beyond doubt, prove that it is this or that.
Yeah.
Anyway.
The other thing, and I don't know if it is, I think it's an important thing to hear from you. The question in this case is usually because it could be like a sexually transmitted disease, but there is a long the carcinogenesis in this condition takes decades, at least years, but decades. So that's basically I'm trying to convey towards the clinicians that it doesn't mean if someone has this kind of lesion that he was unfaithful to the other partner. So that's sometimes a big issue. That's the big part of these calls and that are coming from clinicians, at least to me.
Absolutely. No, I totally agree. All right, so let's move on. And this is just to show you some condyloma accuminata, and you can imagine that clinically sometimes it can be hard to make a distinction from seborrheic keratosis. So the next entity we're talking about is, what clinically will appear as a horn, because this is a sub that sticks out, and the vertical process of the vertical amount of the horn is in proportion to the epidermis is much taller than rest of the epidermis. And so these are the features of a cutaneous horn. The important thing in the horn is not the horn itself, because the horn is dead and you're not being able to make really any definitive diagnosis, but what's the underlying structure under the horn, which can be totally benign or totally malignant. In this case, it looks benign because there is no atypia. It looks like it could be a seborrheic keratosis, it could be a verruca vulgaris, or any other. And you see, that's why it's very important to do a biopsy which includes the epidermis. Biopsy, and they will biopsy here like a shave biopsy, or maybe have a little bit of epidermis, then we cannot give a definitive diagnosis because we don't know what is underlying that. And so it's extremely important that the clinicians do a biopsy which includes the base of the horn. A lot of time people think that they are giving us a lot of tissue, like, because if you see from here to there, oh, I give you a big huge piece of chunk of tissue and you still don't have a diagnosis, because I don't have a diagnosis because I don't have the base of it. So it's extremely important to see the base. And now if you see this base, there is atypia. So, and similarly here, you can begin to see large atypical keratinocytes, parakeratosis, features of actinic keratosis. And in close-up or higher magnification, you can see the atypia very clearly. In this case, the horn is overlying not only actinic keratosis, but superficially micro-invasive squamous cell carcinoma, as you will see in a few minutes that we'll talk about squamous cell carcinoma. And this is just a close-up to show the highly atypical squamous epithelium. So it's very important to have the base and to understand what is a cutaneous horn. And this is an example of just a cutaneous horn. And few more examples. They can be very small, like this, or huge, forming really like horn. So taking just a pause for 1 second to talk about the next topic will be the malignant tumors. But I also wanted to give you an idea that there is a atlas which is available online, which is completely free for you to use. There is no cost for you to learn from this. And many of the photographs that I have shown are actually borrowed from this atlas. There is a iBook version of it, which is a nominal cost, and that one can use on iPad or iMac. And the advantage of that one is that you can make your own notes, and you can look up anything online by clicking on any of the word over there. So personally, I like that. But the atlas is completely free for you to use. And if anybody has any questions about any of the things that I'm talking about, feel free to browse it, and you'll be able to get to see what I just showed you. And it's dumbpathatlas.com. That's the website. Okay. A little bit of commercial. All right. So let's go to the next topic of the malignant tumors of the epidermis. And I'm going to talk about squamous cell carcinoma in situ, squamous cell carcinoma, pseudocarcinomatous or pseudoepitheliomatous hyperplasia, and basal cell carcinoma. Now, these are the features. These are the typical features of squamous cell carcinoma in situ. You can see parakeratosis, you see epidermal hyperplasia, and the epidermis is totally disorganized. There is no normal progression from basal layer to the stratum granulosum. You see frequent mitosis, atypia, large keratinocytes. These are the features of squamous cell carcinoma in situ. And conceptually, I tried to make this in a diagram. This is the normal epidermis on the left upper hand, and you can see the normal on. But the degree of squamous cell carcinoma in situ goes through various stages to become squamous cell carcinoma in situ, as you see in the bottom right hand. And it goes through the process of where there's a mild or moderate atypia to severe atypia to carcinoma in situ. This is nothing magical, because this has been very well described and discussed in human uterine cervix. Man, the people, in fact, now they don't use the term in situ. They talk about cervical intraepithelial neoplasia, grades 1, 2, 3, or whatever. And so similar process, one should think this is happening in epidermis, although we don't talk about it. We talk about it in a way when we don't see the full thickness atypia, magically we call it actinic keratosis. When we see the full thickness atypia, we'll call it squamous cell carcinoma in situ. In my mind, this is not a valid argument, and it's not a right approach to think, because clinically, and I am sure some of my colleagues will not agree with me, there is no such thing clinically as squamous cell carcinoma in situ. There is actinic keratosis, there is Bowen's disease, there is pulmonary papulosis, there is squamous cell carcinoma. But I haven't seen anybody making a diagnosis of squamous cell carcinoma in situ on clinical basis. So, as I was mentioning to you before, that all of these things that we look under a microscope, we should correlate with the clinical findings. And with that idea, let me just show you some examples. So this is actinic keratosis. You can see, typically, any of my colleagues will call it very easily. You have only the lower 1/3 of the epidermis showing atypia. In this case, the atypia goes up to the 2/3 of the epidermis. You can see this keratinocytic atypia. There may be parakeratosis. Usually is parakeratosis, which is alternating with orthokeratosis. Orthokeratosis is overlying the appendigeal epithelium or orifices. And here is almost full thickness, but still there is stratum granulosum. So all these things are called by people. The moment they see this full thickness from here to here, this becomes squamous cell carcinoma in situ, which is fine. You can call it histological squamous cell carcinoma in situ. I have no problem with. But the problem is this. Let me show you. So this is actinic keratosis clinically. Now, if you biopsy, and you know that most of the actinic keratoses are treated by liquid nitrogen, by freezing. So you don't know what you are freezing. You have no clue what the histology was. And I can tell you, because I was involved in a project where we did about 2,000 actinic keratosis histology for a study for effects of retinoids. And in almost all of them, because there were multiple sections were made, I was able to find changes focally of squamous cell carcinoma in situ. So the whole premise would change. Typically what happens is that all my colleagues, and I've tried to talk about this thing over many years to many people, they still don't necessarily subscribe to my idea, because clinically this is actinic keratosis. So what happens is, when histologically we call it squamous cell carcinoma in situ, the clinician at their end, they think squamous cell carcinoma in situ, and they go on to go and excise it. And I have seen huge excisions on 80-year-old and 90-year-old and 100-year-old people on their face for, they call it squamous cell carcinoma in situ, when it is really actinic keratosis. Okay. So once again, changes what one sees in actinic keratosis can including up to squamous cell carcinoma in situ. And if you look at the original Lever's book, he describes squamous cell carcinoma in situ in actinic keratosis. Other features typical of actinic keratosis, I mentioned this alternating parakeratosis with orthokeratosis, which are typically correspond to the acrosyringium. They can be hypertrophic, right? And hyperkeratotic. You can see this hyperplastic, or they may be atrophic, where the epidermis is not really thickened, but there is still showing keratocytic atypia. They can be pigmented, just like seborrheic keratosis can be pigmented, just like any other epithelial tumor can be pigmented, and it is indeed due to the presence of highly active melanocytes which are producing large amount of pigment. It may be lichenoid. You can see a band-like infiltrate, or maybe acantholytic, not to be confused with acantholytic acanthoma, because remember there the acantholytic cells and the epidermis is not showing any epidermal features. Not to be confused with pemphigus or other acantholytic disorders, because these acantholytic cells and this epidermis is highly atypical. So it is extremely important to make that distinction. Acantholysis is not only confined to epidermal or epidermolytic acantholytic bullous disorders, can be seen in malignant conditions. Okay, so this is my point about actinic or solar keratosis. Now, this is so-called Bowen's disease, which we really don't see anymore because people are not taking arsenical things. People used to get visceral malignancies. I haven't seen one case of Bowman's disease in the last 35 years of a clinically proven, histologically seen Bowman's disease, so-called squamous cell carcinoma, in situ associated with a visceral malignancy. Leslie, have you seen any such case?
No.
So that's my point. So so-called Bowman's disease, if you read the books, it always says the Bowman's disease is associated with visceral malignancy because people are not doing anything. They're not taking in arsenical stuff. And so we don't see that anymore. So in any case, if you see a lesion which is not on sun-exposed area, which is on sun-protected areas, and you will see lesions like that, which will show histological squamous cell carcinoma in situ, I'm perfectly willing to say that this is so-called Bowman's disease, which are not necessarily associated with visceral malignancy, but may require an excision, because this is not a solar elastotic. In all the actinic keratosis, you will find marked solar elastosis, moderate to marked solar elastosis, and that's a different beast. That's actinic keratosis, which can be treated by cryotherapy, by FUDAX, by curettage or whatever. Does not require huge excisions. And that's the only thing that I want to appeal to you, that as young people who are growing into the practice, do not have this urge to take out huge excisions for the so-called squamous cell carcinoma in situ, which are seen on sun-exposed areas. In histologically, Bowman's disease can show this wind-blown effect where the entire epidermis is affected and it appears very vacuolated. And as you can see, sometimes you can see the mitotic figures very high up in the epidermis. If you didn't see the mitotic figures, you may confuse with a wart, with a colicid chain, but the ATP, the nuclear ATP at the side of the is quite marked. Here is an example of squamous cell carcinoma in situ with multiple mitotic figures, as you can see here. Okay. Another helpful feature in squamous cell carcinoma in situ is this presence of this so-called eyeliner sign, where the basal keratinocytes seem to be preserved. But it's not by no means that it is only confined to Bowman's disease. I've seen in other situations, and in so many squamous cell carcinoma in situ, you may not see this sign as you see in this next modified photomicrograph. Just as seborrheic keratosis be clonal, you can see the same kind of a change in a Bowman's disease or in squamous cell carcinoma in situ. You can see this clonal type of arrangement or nested arrangement. It may show pidgetoid type of configuration. There's atypical keratinocytes are dispersed in a pidgetoid in a scattered manner throughout the epidermis. It can be confused with melanoma. It can be confused with Paget's disease. And this day and age, we have special stains, immunohistochemical stains, which will distinguish this from melanoma. If you do a Martwell stain, for example, or a Salk stain, that will take the diagnosis, exclude the diagnosis of melanoma. If you do even a PS stain or L-shaped stain or gross cystic fluid protein stain or even keratin low stain, that will distinguish this from extramemory Paget's or Paget's disease. And all of these changes, by the way, can be seen in actinic keratosis. It's not, again, confined to that. Sometimes the configuration may be very spindly in squamous cell carcinoma in situ. And again, making a distinction by doing immunohistochemistry with keratinocytic markers and melanocytic markers can make the distinction. In this case, you can see the high molecular keratin weight, positivity, absence of melanocytic markers or Martwell staining excludes that this is a melanoma in situ. So these are all the features of squamous cell carcinoma in situ, or so-called Bowman's disease. But look at this case. This is the unfortunate story of a 21-year-old young woman who had bilateral vulvectomy for these lesions. So clinically, these lesions are skin color to hyperpigmented papules, multiple papules in this young woman. So already by now, you're thinking, what is the clinical diagnosis? The clinical diagnosis in this case is Bovenot papulosis. Bovenot papulosis, believe it or not, shows same exact morphology as Bowman's disease. That's why the term Bovenot papulosis is the same histology that you see in the squamous cell carcinoma in situ of actinic keratosis. Just as we will not do a huge excision of Bowman papulosis as in Bowen's disease, we should not be doing the same thing in actinic keratosis. So this is malpractice. This poor woman had bilateral vulvectomy because the pathologist who was signing this case out, a general pathologist, he didn't know the history. He didn't know the story. He saw this, and I won't blame him for that. If I look at this case, I would also call it squamous cell carcinoma in situ. It has all the features of squamous carcinoma, multiple mitotic figures throughout epidermal, epidermis, epidermal and transepidermal ATPs, the so-called transepidermis, and the entire epidermis is involved, is classical for squamous cell carcinoma in situ. But there is something wrong because clinically it has multiple lesions on the genitalia. Who will get multiple squamous cell carcinoma in situ? Patient is not, unless the patient is on speech or has xeroderma pigmentosum or some other syndrome, not possible. So there is something disconnect, and so pathology should ask, this is a young person, is a multiple lesion, and the clinician should ask the same question to the pathologist. So if there was a dialogue, if there was a CPC, this problem could have been resolved, and this poor patient would not have had her vulva removed or excised because of the diagnosis of squamous cell carcinoma in situ. And that is how strongly I feel so passionately about the actinic keratosis, that they should not be excised with wide margins just because the pathologist has called it squamous cell carcinoma in situ, because these are actinic keratosis. Similarly, these are Bowman papulosis. You ask any dermatologist today, they will not excise, they will not do this huge excision for Bowman papulosis. So what I want to leave, so this is an example of arsenic keratosis clinically, microscopically, that looks the same as any of these entities that I showed you, but we don't see this anymore. I haven't seen a case of arsenic keratosis in the last 35 years also. And once again, the features of squamous cell carcinoma in situ. So last entity of squamous cell carcinoma in situ is erythroplasia of Kerward, which shows abnormal squamous cell carcinoma in situ of the glans penis. Okay, and so in the end, I want you to be going away with this idea that squamous cell carcinoma in situ is a histological term in which there are clear-cut changes that one sees, and you can make that diagnosis. But clinically, it has a very different connotation. It could be actinic keratosis, it could be Bowman's disease, the one which is I showed you, which is sun-protected area, Bowman papulosis, arsenic keratosis, erythroplasia of Kerward. And if I have conveyed that much today to you, I think I have succeeded in my talk. So, all right. Do we have time to go on for a few more minutes to talk about squamous cell carcinoma?
Yeah, right? I think so.
Okay. So squamous cell carcinoma, as you said, chronic overexposure to sun is the primary cause of nearly all squamous cell carcinoma. And these are usually seen in sun-exposed areas. And when they're seen on the lip, for example, they are more virulent and in their prognosis than when they are seen on other areas. They can be seen in burn or in scars or long-standing sores. And again, in those situations, they are much more aggressive in clinical appearance as well as in their prognosis. But most typically, the squamous cell carcinomas are the invasive inward growth or endophytic growth of squamous epithelium. But this squamous epithelium, unlike in seborrheic keratosis, you can see that, and you saw even in irritated seborrheic keratosis, these pearls or these squamous eddies are highly atypical. You can see central keratinization, the so-called squamous pearls or keratin pearls. They're lined by the atypical squamous epithelium at the periphery and more mature epithelium in the center. So the normal epidermis is growing outwards and you see the stratum corneum, but here all these individual islands are are keratinizing in the center, and that's why they're called forming these pearls. They may be infiltrating down into the dermis like that you see with the inflammatory infiltrate and sometimes fibrosis. So these are the features of a well-differentiated squamous cell carcinoma where you have classical squamous epithelium which sort of recapitulates the overlying epidermis because it has other features of epidermis except that they're atypical. But you can at least make a distinction that clearly this is squamous epithelium, and that is why we call it well-differentiated squamous carcinoma. They may have sometimes intraepithelial abscesses, neutrophils, or other inflammatory cells. They may have giant keratinocytes, multinucleate keratinocytes, abnormal mitotic figures. You can see in the stromal infiltrate, there can be even eosinophils. I don't know the significance of it. And people have described these as well-differentiated, moderately well-differentiated, and poorly differentiated to give some sense of the aggressive nature of these lesions. And this will be classified as moderately differentiated because you don't see the classical keratin pulse that you saw in the well-differentiated form. But there are areas where you can see some keratinization here, the keratinization in the middle. So you can say, well, I'm still dealing with squamous cell carcinoma because I'm seeing some features. And there are intercellular bridges. If you go in higher magnification, you'll be able to see them. As you can see here, there are some intercellular bridges. So one knows that you're dealing with a squamous epithelium, and this is a squamous cell carcinoma. But when it becomes poorly differentiated, when there is very difficult to know what differentiation this is, then you don't see keratinization, you don't see squamous pulse, and we call it poorly differentiated squamous cell carcinoma. It may show acantholysis. It may be forming little glands because of the so-called acantholysis, then they appear sort of glandular or pseudo-glandular. And in these cases, we need immunohistochemical stains to confirm the diagnosis that this is really a squamous cell carcinoma. But even in these cases, if you are careful enough, and you will find areas of individual cell keratinization. Imagine that when I started off, there was no immunohistochemistry, and we had to make a diagnosis based on histology. And we were able to find, again, if you do multiple sections, you do multiple block levels to see there might be focal keratinization in some areas that will give the clue, and we will be able to make the right diagnosis of squamous cell carcinoma. But in these days, it is easier to do an immunohistochemical stain. And this immunohistochemical stain with keratin staining highlights all the epithelial structures. So this is a poorly differentiated squamous cell carcinoma. Okay, so squamous cell carcinoma, well, moderately, and poorly differentiated type. This is just to show you that people talk about that you can see retraction artifact typically in basal cell carcinoma. We'll see in a few minutes, but sometimes the retraction artifact can be seen also around the islands of squamous cell carcinoma. So it's not confined only to basal. It's not common, but it can be seen. And you can see this large, giant keratinocytes, many mitotic figures that I talked to you about. You can have a very clear cell type of squamous cell carcinoma, or a signet ring type of carcinoma where it appears like a mucin producing adenocarcinoma. But these are really squamous cells. They have intercellular bridges. And if you do stains with keratins, it will confirm the diagnosis of squamous cell carcinoma. But they are variants of squamous cell carcinoma histologically that one should be aware of: the clear cell pattern and the so-called signet ring pattern. Again, they can be pigmented, and the pigment is because of melanin and because of melanocytes which are producing more pigment. So remember, any of the epithelial tumors, benign or malignant, can be pigmented. They may show epigenetic spread, just like in squamous cell carcinoma in situ or Bowen's disease that we saw, or in Paget's disease or in melanoma. They can have a epigenetic pattern. There may be acantholytics, just as in actinic keratosis or in squamous cell carcinoma in situ, and large portions of the tumor may be acantholytic. So again, there is no clinical significance to this acantholytic type of squamous cell carcinoma. But again, note that the acantholytic cells are highly atypical. They have a nuclear cytoplasmic ratio. You can see the nucleoli in many of these things. They are hyperchromatic, and they're not the normal nuclei of normal epidermis. Sometimes the squamous cell carcinoma can be spindle. You can see the marked spindle nature of this thing. In these cases, it can be confused with other spindle cell tumors, even mesenchymal tumors, because the intercellular bridges may not be easily seen, and it can be confused with spindle cell melanoma and so on. And once again, one will have to resort to immunohistochemistry unless you find areas of keratinization in some places which you can. In that case, you can be confident of the diagnosis. Otherwise, you have to do stain. Imagine this is also a little bit pigmented, having melanin. That would be even more confusing to make this diagnosis. And so this is spindle cell carcinoma, squamous cell carcinoma. And here you can see clear-cut squamous differentiation with keratin pearls. So we know that this is a squamous cell carcinoma and not perineal invasion. One should look for it. It can be seen and it should be reported because these are high-risk malignancy. The other high-risk feature is the size of the lesion. They say if it's over 2 millimeter, then we have to report nowadays that this is high-grade squamous cell carcinoma. The other variant of squamous cell carcinoma is this typical dome-shaped structure which has invagination and the so-called keratoconthoma. And in the past, the keratocanthomas were considered to be a separate entity, but most people, most pathologists feel that squamous keratoconthoma is another variant of squamous cell carcinoma. And so we report these things as squamous cell carcinoma keratoconthoma type because they have this central crater-formed lesion filled with keratin, and the epithelium is more glossy cytoplasm. It has less atypia that one sees that in squamous cell carcinoma, but they can behave as aggressively as squamous cell carcinoma. People in the past described that if you see intraepithelial elastic fibers, that is a sign more for keratoconthoma than for squamous cell carcinoma. But I have seen this in verruca vulgaris, I've seen this in squamous cell carcinoma, so this cannot be really taken as a very helpful sign. But these are the elastic fibers that we're talking about that can be seen within the epithelial masses. Okay. There is a valid entity of keratoconthoma when there are in a syndrome such as this. There's multiple lesions, and you can see in this patient there are some spontaneous regression of many of these lesions, which are leaving scars. And there are several of these multiple keratoconthomas which may be associated with immunosuppression or Ferguson-Smith syndrome or Zerkowski syndrome or Muir-Torres syndrome. I'm not going to go into that. You can read about it, but just to know that multiple keratocanthomas can occur. Another entity that we should know, and we see it not that rarely, is the so-called resolving or resolved keratoconthoma, because here you can see that there is a keratinous mass. There's a crateriform mass which is filled with keratin, but there's hardly any epithelium left at this point. These are all dead keratinocytes and keratin, some fibrosis at the base, some inflammatory infiltrate. So this is a resolved keratoconthoma, resolved squamous cell carcinoma, which is of a keratoconthoma type. And that's why people think that, because people talk about the resolution in keratoconthomas, because sometimes they say that these things spontaneously resolve, and that's why it's a different entity. But because of the fact that some lesions can metastasize and locally recur, people now think more comfortable in calling them as squamous cell carcinoma of the keratoconthoma type. But there is definitely entities that we see which seems to show almost complete regression or resolving lesion, which will be classified as resolving keratoconthoma. Okay. Another variant of squamous cell carcinoma is the so-called verrucous carcinoma, in which you see this exophytic growth. And if you biopsy this shave like this, I can guarantee you, which has happened with me, particularly in one case, where we got a superficial shave biopsy without much clinical information, a lesion on the penis. And I, of course, made the diagnosis of condyloma or seborrheic keratosis, I forget what. And then the clinician sent me actual photograph of the lesion of the penis, which is a very fungating large mass. And we almost don't need the biopsy because this is clinically a cancer. So it's very important to know how you biopsy these lesions. And if you only biopsy a superficial portion, it may appear as a benign lesion, as you can see in this case. You can see if you just biopsy the upper part, it will appear wart-like verrucous. So these verrucous carcinomas are special variant where show endophytic and exophytic growth. The endophytic growth may show some atypia, And that's how one makes a diagnosis. But if you only saw the exophytic portion, it will be very hard to make a diagnosis. But at the base, you can see the atypia that you see, the similar to squamous cell carcinoma. Very tricky lesions and sometimes very difficult. And this is the lesion that I was talking to you about, the carcinoma of the penis, where the clinician gave me a very superficial shave, which I called as a wart, but it was actually a squamous cell carcinoma or verrucous carcinoma. The next entity, I think, Laszlo, I don't know if because I have still basal cell carcinoma. I mean, I'm happy to do it on a different time.
Yeah, I think it would be maybe good to let the audience go, because I mean I absolutely enjoy this, you know, and I think that everyone also, you know, what is basically the great thing in this talk, that you are covering like our, let's say, 80-90% what we are doing day in and day out. So the seborrheic keratosis, squamous cell carcinoma, actinic keratosis, the different variants of squamous cell carcinoma in situs are the bread and butter of dermatopathology. And to have your perspectives on this is absolutely.
I'm sorry, a little bit of maybe controversial, but I at least wanted to give my viewpoint, you know, and hopefully someday some people will agree to that viewpoint, or they will form their opinion as the time will show. But I feel that I need to do the right thing. So I'm happy to do the remainder, and then I can talk about maybe some other variants of squamous cell carcinoma that I could not finish here, and other things that we can expand on that.
Yeah, I mean, if you have a little bit of time, then maybe even for a half an hour lecture, we will talk.
Yeah, absolutely. We can do that at any other time. You know, I'm happy to come back.
Fantastic. Well, Jag,
if
thank you so much.
Now, from the audience, I'm happy to answer.
Okay. Do you guys have any questions for Professor Bawan? One thing that if until you are thinking about the questions, is that what would be your practical clue between benign and malignant, or reactive and truly neoplastic proliferation? You showed a picture of a well-differentiated squamous cell carcinoma, and there was a verrucous lesion on top of it. And a lot of times we are running into that issue, you know, that if you are cutting deeper, or you actually cannot really cut deeper, and there is carcinoma below. So do you have any kind of magic clues that can a difference?
Yeah, I wish I had. I think the most important thing is really the clinical. Because I will show you next time an example of a squamous cell carcinoma, which we call it a verruca vulgaris, a classical verruca vulgaris. And then we, of course, got the clinical photograph, and then we got the excisional specimen, which shows classical squamous cell carcinoma. But it shows the top part is nothing but classical what features of a verruca vulgaris. So I don't think there's any clue to not having the sample right, or not having the clinical right. So that is why in my talks, my emphasis and my classical talk is the CPC, which I give all over the world, and I emphasize that fact that we really need to have a CPC in order to have the right diagnosis, because just only in pathology or only in clinical we cannot win, and it's a team effort. And in this day, there was a time when I was growing up as a resident in pathology back in early 1970. We were told that pathology is like the God. You look at the microscope, you make the diagnosis and move on. But no longer is the case. We can't do that anymore. It is always a CPC. So I think that's my only 2 cents, Laszlo, about that.
Thank you so much. So with that, I think that we finished the meeting here, and I'm going to reach out to you regarding another session on the end of the squamous lesions, and the audience is thanking you for your time. So you may see that, if you click on the chat window. So again, It was a phenomenal presentation, and we learned a great deal about this lesion. So we are very excited to hear you. And I also want to make an announcement because Richard Carr will be on the program sometimes in January, and he has wonderful ideas about keratoacantomas and follicular-based or follicular squamous cell carcinoma. So that would be a very enlightening lecture to attend
I
as
will try to attend that so that I can also learn. That'd be wonderful.
Yeah.
Thank you. Thank you so much once again, everybody.